I'm Barbara Conkle. I am a professor of medicine at the University of Washington and chief scientific officer at BloodWorks Northwest, where I also am co-director of the Washington Center for Bleeding Disorders. Today I'm going to talk about gene therapy and hemophilia, and specifically adeno-associated viral or AAV vector gene therapy and its application to hemophilia. So the learning objective is to identify key characteristics of current clinical trials in gene therapy for both hemophilia A and hemophilia B. We think about gene therapy, it's pretty simple. We have a gene that is put into, we're speaking about AAV-mediated gene therapy, so put into the AAV vector and then injected peripherally. And due to the vector and the promoter enhancers, which we'll discuss later, it is directed to the liver, which is the target cell we'll be discussing. AAV is essentially extrachromosomal, and then the protein is produced. Although what happens in the target cell, still there's a lot that is a black box that we need to understand more. There have been an incredible number of animal models in gene therapy and now over 200 human trials of different diseases using AAV-based gene therapy that have been conducted in the past 30 years. So specifically about the AAV virus, shown at the top is the wild-type virus. It has a rep and cap gene, which are removed for the vector. The wild-type AAV is a member of the parvovirus family. It has about a 4.7 kb single-stranded DNA genome. It is replication deficient, so it requires a helper virus, and that's actually where it got its name because it was found as a contaminant of an adenovirus culture, but it has nothing to do with adenovirus other than having been discovered in that way. It is non-pathogenic and it naturally infects humans. For AAV vectors, they are replication defective. They, as we'll see on a subsequent slide, there's both naturally occurring and bioengineered vectors. The viral capsid governs where the vector goes, the tissue tropism. It's been documented to have long-term expression in postmitotic cells, and it's predominantly non-integrating and very important to date. It has a good safety profile in animal models and in human trials. As noted previously, we are exposed to AAV. About 30 to 50% of the population have antibodies to AAV, and most commonly to the AAV2 serotype. There was a nice study where they took samples that had been collected from 62 boys over time as part of the Hemophilia Joint Outcome Study and looked at the development of AAV seropositivity early in life. And shown in the graph on the right, you see that these boys became exposed to AAV, and most commonly AAV2. This study looks specifically at AAV2, AAV5, and AAV8. To use these vectors for hemophilia, there's been work over the years to improve the expression. Initially, there was a concern that immune response to the capsid could be decreased by removing empty capsids, which sounds like a good idea and probably is, although whether that has modulated the general immune response is unclear. There's use of different AAV serotypes. Initially, AAV2 was used, and then others have. There's less seropositivity in the population, as well as varying tissue tropism. There's optimization of liver-specific promoter and regulatory elements to be sure that it is targeted to the liver. Shown in the figure is a CMV promoter, but other promoters are used. The scientists also optimized the codon to increase factor 8 and factor 9, and two modifications that really are now uniform. One for factor 8 is to use a B domain deleted factor VIII to allow it to be a size that can be inserted into AAV. And then the Padua variant in factor IX, this one amino acid change was discovered in a family in Padua, Italy, who had very high factor IX activity levels. And it was due to this one variant. And so, as we'll see, by inserting that in the factor IX cassette, we can markedly increase the specific activity of the factor IX. So the first AAV-mediated trial in hemophilia was actually intramuscular injections. This was done at the Children's Hospital of Philadelphia, and there was really not systemic expression, but interesting, when they went back and biopsied muscle later, there was persistent factor IX gene expression. The first liver infusion was with an AAV2 factor IX construct, and shown on the graph on the right is from the manuscript, and in the high dose, factor IX actually increased initially, shown in the red line, to about 12%, which was incredibly exciting. But then there was an increase in the liver enzymes, in the ALT notably, and that was associated with a decrease in factor IX expression. And this was very surprising, in part because the studies were based on dog models, and this did not occur in the dogs, showing that people aren't dogs, but still it was a surprising finding. Subsequent, there was a patient infused who had pre-existing AAV2 antibodies, and he did not show a response, presumably due to that. And then they subsequently infused another subject to understand better the immune response, and there was, again, increase in liver function tests, but no factor IX expressed. The first long-term expression is from the St. Jude UCL study, and shown on the right is from their publication. The first follow-up, we now have the longest out individuals up to 8 years, and they continue to show expression. These show the gold lines are factor levels, and the blue arrows above are factor infusions. So you can see the factor going up and down with the infusion, but then really stable factor expression as the dose escalated from about 2 to 6%, which persists. An important thing we learned in this trial is that when there was an increase in the ALT, as shown in the green arrow, and you can see in patient 5 how there was a sharp increase, and they instituted prednisone therapy, and they showed that they could retain factor activity through the institution of prednisone therapy, and this is an approach that is used in all the gene therapy trials to date. So here's a table of selected ongoing phase 1, 2, and phase 3 trials. There may be something left out here. It's not meant to be exhaustive, but to illustrate kind of where the field is. It also is a fast-moving field, and so these by nature can be out of date. Shown first are the hemophilia A, and then the 3 hemophilia B with their sponsors and different names. The vectors, as you'll note, have different serotypes. Also, there are some engineered vectors, the Spark 100 and the AAV HU37, the Ultragenics. The cells used for manufacturing are either insect or mammalian. The value of the insect is that they can produce more, but there is different post-translational modification. We don't know at this point whether this makes a difference. And then in the next column is the phase of the trial. So the BioMarin is the farthest along. In phase 3, they had 2 doses, and these are vector genomes per kilogram, although the enrollment has really been in the higher dose. The phase 1-2, there is an escalating dosing in order to determine the dose to be used in phase 3. The Spark phase 1-2 factor VIII is now in observational phase, which is performed for at least 6 months to have the patient write down or put in their electronic diary their treatment regimen and any bleeding, so that once they receive gene therapy, then the results can be compared to the patient prior to gene therapy, to his own data. In hemophilia B, there are 2 trials in phase 3. The Pfizer has phase 3 of what was the phase 1/2 SPARK trial. Then there's a Unicure trial also in phase 3, and earlier is the Freeline trial. So what do study results tell us to date? So some of the published or presented results from a few of the trials will illustrate kind of where things stand. So this is the AAV Factor 9 Padua AMT-061 trial. And this trial began, shown on the left, the AMT-060 in the figure, was the first in terms of phase 1/2, and they achieved a factor 9 of around 7.5%, which when I started in hemophilia would be unheard of. Even after I started in hemophilia, we thought in gene therapy, if we could take patients just into the mild range, which this would do, that would be success. And really it has been success. If we look at the trials where there's persistent levels of 6%, those patients are not infusing, they're not bleeding. But we know from more recent trials that we can achieve higher levels. And so what they did was they took their vector and they added the Padua variant, and they infused that into 3 subjects, and results up to 36 weeks are shown here. And actually they have subsequently at ASH presented later data. And in these 3 participants, the mean factor 9 activity at 36 weeks was 45%. Interesting, in this trial, they did not require immunosuppression, and patients had low titer seropositivity for AAV5, which raises a question of whether patients can be infused with some vectors if there is evidence of antibody response. And this study is in phase 3 at this dose. This shows the 2-year update of the AAV Factor 9 Padua Spark 901 study, which shows expression up to 29 months. It shows some variability in expression, but all at levels that would have a significant clinical impact and have shown to really eliminate the need for factor infusion and bleeding. This BMN 270 was the phase 1/2, which is now in phase 3 at this dose, the 6 × 10^13 vector genomes per kilogram. And these are the 3-year results with the chromogenic assay. Initially with this vector, there were levels well into the normal range of factor 8, which have decreased some over time, but still with a median range of around 40, which is certainly remarkable. And I think we'll have to see, because this trial is the farthest out, we'll have to see, is this what we will see for the other factor 8 trials? And we really don't know at this point. Another factor 8 gene therapy trial is the ALTA trial. And this is an update of results that were presented at the recent ASH meeting. This is the phase 1/2, and you'll see at the top, these are subjects who were dosed from 2 to the 12th, but the highest dose cohort is 3 × 10^13. There is a dose effect, and then you can see on the left-hand panel is the factor 8 activity in a linear graph, which nicely separates the results, and then the logarithmic scale demonstrating that the patients in the high-dose cohort achieve levels in the normal range. Again, this is early, and so we'll have to continue to follow these subjects over time. And this vector will be used in a phase 3 trial that's being conducted by Pfizer. So overall, there are some really positive things with AAV gene therapy and some continued challenges and questions. So one of the issues is limited patient eligibility. So current subjects, they can have no history of inhibitors, although I have to say there are a number of studies that are being developed to look at inhibitors. So that likely will not be true in the future. They're adult males. For factor VIII, generally, they require less than 1%, although that's becoming a little more lenient, and with factor IX, less than or equal to 2%. Patients who have pre-existing antibodies to the AAV vector are excluded. Unicure, in their hemophilia B trial, have low titer vector positivity. And so whether that has to do with the titer or whether that has to do with the serotype in terms of still having efficacy, I think we don't completely understand. So future patient targets are current or past inhibitors, and Spark has a trial, and there are other companies who are working on protocols for trial. The pre-existing anti-AAV antibody is an issue and excludes a number of patients. Less severe hemophilia, adolescents. The issue with AAV is that it is non-integrating, but that also in the liver, it will be lost in a growing liver. And so that would certainly at this point limit it in young children, and we don't know in terms of as we go down the age where that would lose its efficacy. There are females with severe hemophilia, and that also is being loosened a bit in terms of some protocols allowing females. And then the patients who lose expression or were in the early phases of study and did not get a result, also there's not an answer for them in terms of AAV therapy, and there are not other approaches for gene therapy in hemophilia that are at the same phase. So what are the risks? We have really good therapy for hemophilia now. So as we consider it for our patients, we have to be sure that the benefits to patients are greater than the risk. So we have some known risk, and one is the short-term liver toxicity that is seen in some patients in virtually all the trials. And that has, in general, responded to short courses of steroids. But from several trials, we know that a few patients have required longer treatment of immunosuppression, and so that raises questions about toxicity. Patients will develop anti-AAV antibodies if they are exposed to the virus, which will, at this point, preclude their receiving additional dosing. And we also know that there generally has been really a wide inter-individual expression, variability in expression, which is partially explained by the anti-capsid T-cell immune response. But we know that we've seen patients who are losing response or have a decreased response who don't have evidence of this. And there are different theories as to why that may be, but I think at this point we really don't understand it. So there are also unknowns. We don't know if there will be long-term liver toxicity. We don't have evidence of that now, but it's something that's going to be very important to follow up. AAV, as I mentioned, has a very low integration rate. However, we're giving 10 to the 13 viral genomes per kilogram, so there does become a real number. I think we can be reassured by the large number of patients who've received AAV in multiple trials for different diseases, but this is something that we will need to watch closely. There is not evidence of germline transfer. Animal models do not support it. In human studies, there is vector detected in the semen, which clears, but there's been no evidence that it is in the sperm. So that is reassuring. So in summary, AAV-mediated gene therapy has been successful in increasing factor VIII and factor IX levels in patients with hemophilia, and at all different levels that have been achieved, it has markedly decreased factor usage and decreased bleeding. To date, from hemophilia and other AAV trials, it appears to have a very good safety profile. However, we need to be vigilant in our long-term follow-up to look at any safety signals. We also need long-term efficacy data to understand if this expression will be transient over years, because we know we can see expression for years at this point. Will that last? Will that go away? We really just need long-term data on that. And then modifications of approach with AAV and use of other vectors so we can treat a broader hemophilia population, including young children. Thank you.